further delay, I would like to introduce our speaker, Dr. Fuad Muhammad. He's working currently with us in hepatology department. He's holding double major, bachelor degree in medical laboratory technology and also bachelor degree in medicine. He is qualified as internist, gastroenterologist, as well hepatologist. And without any further delay, the floor is yours, Dr. Fuad.
Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Hadi. We're going to start our presentation. I'm Dr. Fuad Muhammad. We're going to start our presentation today about hot topic worldwide and very interesting for all of you and for us, especially as hepatologists, which is non-alcoholic fatty liver disease. And we'll try to concentrate today on why NAFLD is important, why it is we are saying it is emerging epidemic, and is there any hope for the future therapies? We're going to talk about the current therapies and future therapies. So let's start with the outlines. We'll present a case, short case, for introduction to the NAFLD, then we'll proceed with the lecture. In the lecture, I'm going to present about the NAFLD in brief. What's the prevalence, why it is epidemic, natural history of NAFLD, then go to directly to the treatment. What treatment available nowadays regarding weight reduction, pharmacotherapy, then what are the ongoing trials for future therapies, and anything going to be released soon or not. Then I will conclude my lecture. So we'll start with the case presentation. So Mr. M is 66 years old, male patient, newly diagnosed as NASH-related liver cirrhosis outside, with decomposition history of ascites 2 months ago before presentation to our clinic. He presented to our clinic for further evaluation. So upon presentation, patient was clinically asymptomatic, fully conscious oriented. No further history can be taken from the patient apart from negative history for alcohol intake, negative history for surgeries, IV drug use, negative history for herbs or drug abuse, and no family history of liver disease or liver malignancies. His investigations, clinically patient fully conscious oriented, mildly jaundice, abdomen soft lax, no clinically appreciable ascites, no lower limb edema. Investigations showed sodium 134 as showing here, creatinine normal, total bill was 38, albumin was in the lower side, 29, ALT INR also borderline high. CT scan done showed liver cirrhosis with signs of portal hypertension and 2 liver lesions characteristic of HCC LERAT5 radiologically. So patient underwent bridging TACE, which is transarterial chemoembolization before liver transplant. His tumor partially responded to chemoembolization and was discussed in tumor board, and the plan was to proceed with liver transplant. So his available donor is his son. He's a 23 years old male patient, no comorbidities, negative viral screening, normal liver test, normal CT scan, MRI liver, and he underwent liver biopsy. This is a picture of the liver biopsy of the patient. You can see it here. You can see the normal cells and portal triad, and you can see how the normal cells are occupied by fat globules, just white in color here. The normal tissue is the pinkish color, and you can see how the normal cells are substituted by fat globules. So this is the biopsy of the donor, not the patient. So biopsy result, histopathological review showed macrovesicular steatosis 20% with no steatohepatitis, there is positive very venular and very cellular fibrosis, no advanced fibrosis or cirrhosis. Should we proceed, Dr. Hadi?
Yeah, continue, please.
Okay. So this is introduction about how significant is NAFLD. The father was diagnosed as NAFLD, complicated with cirrhosis and HCC. The cirrhosis decompensated and developed HCC. We brought the donor who is free for donation, and the biopsy showed again NAFLD in the biopsy of the donor. So let's start an introduction to our topic, which is NAFLD. What do we mean by NAFLD? It is excessive hepatic fat accumulation with insulin resistance. Steatosis more than 5% of the hepatocytes. Normally hepatocytes, we tend to find less than 5% fat or steatosis inside the hepatic cells. We should exclude secondary causes of NAFLD. We'll come to it in a while in the next slide. So NAFLD, by definition, we can classify to NAFL and NASH. NAFL means only pure steatosis with mild inflammation. NASH means there is severe inflammation with fibrosis. And this fibrosis can be early, advanced, and it can reach up to cirrhosis. If you see in the diagram, NASH or NASH, non-alcoholic steatohepatitis, can proceed with fibrosis and cirrhosis, linear progression to HCC, and can proceed to HCC directly, but not NAFL, not without steatohepatitis. So NASH can proceed with HCC, progress to HCC without passing through fibrotic cirrhotic line. So what do we mean by secondary causes of NAFLD? You can see in the right of the table here, the secondary or concurrent cases of NASH, which has the first one, acute fatty liver disease, or alcoholic fatty liver disease, which means a man taking more than 30 grams per day, or a woman taking more than 20 grams alcohol per day. Drug-induced, many drugs can cause fatty liver disease. Hormonal therapies, steroid, amiodarone, so many drugs can cause. HCV can cause by itself, and other comorbidities including hypothyroidism, celiac disease. A lot of comorbidities can cause fatty liver disease without secondary fatty liver disease. Our primary fatty liver disease it is called primary fatty liver disease, and usually it is associated. I will show you in another slide how it is associated with metabolic syndrome, which has the metabolic syndrome, which is the obesity, blood pressure, hypertension, impaired glucose tolerance or diabetes, hypertriglyceridemia, hyperlipidemia. So 3 out of this usually they are at risk of NAFLD, or there is a great association between NAFLD and metabolic syndrome. Here it's a diagram showing why NASH develop, or why people develop NAFLD, or non-alcoholic fatty liver disease. There are many theories why some people tend to have NAFLD and some people tend to have not to have NAFLD. The main theories coming from insulin resistance. People who have insulin resistance, they have problem with the lipogenesis, because the insulin is the main hormone for lipogenesis. So they have problem with the insulin resistance. There's insulin resistance, and they release, instead of accumulating fat in the adipose tissue, they release free fatty acid in the circulation. This free fatty acid will go to the liver for metabolism, which is the main area of metabolism of fat and other molecules. So when it goes to the liver, it will be, overaccumulated and tend to accumulate fat in hepatic cells. And by accumulation of these fat cells in the fat globules in the hepatocytes, it exceeds the limit. It might lead to ballooning of the cells, ballooning of hepatocytes, and degeneration, and initiate the circle of inflammatory process. So you can see in the diagram there's inflammatory mechanism and there is fibrosis mechanism. The inflammatory mechanism starts many theories, maybe some theories suggest that there is dysbiosis from the gut bacteria translocation goes to the liver and initiate the inflammatory process. And we know with many pathophysiology of many diseases, if inflammatory process is started, then it is hard to stop it. So you can see many inflammatory markers, TNF, IL-1, B, plus the oxidative stress release. After this inflammatory process ongoing, it will activate the hepatic stellate cells. So hepatic stellate cells is one of the important cells in the fibrosis of liver, or progression of NAFL, non-alcoholic fatty liver, to NASH, hepatic stellate cells, which induce fibrosis by activating this fibrotic process and leads to fibrosis and end up with scar tissue. So come to the next slide, which is the prevalence of NAFLD. How important is NAFLD all over the world? Worldwide prevalence of NAFLD is 25%. So 1 in 4 people in the worldwide, they have NAFLD. And 55% of type 2 diabetes mellitus worldwide, there are 55% they have NAFLD with type 2 diabetes mellitus. As we said, insulin resistance is one of the main mechanisms. If you go to our area, Middle East area, in type 2 diabetes mellitus, it is 67% of type 2 diabetes mellitus, they have NAFLD. Is there local data? There is local data released from Dr. Khalid Swad Juma and Faisal Sunai, released in 2017, and they made a model forecast prediction about 2030. What would be the, how would classify NAFLD as a health burden to our system? If you can see they estimated with this using this model, NAFLD in 2017 cases estimated to be 8 million total cases of NAFLD. But in 2030, the estimated cases will be 12.5 million. So we can see the great increase. And they found, they based on what? They based on the local data and the evidence available, prevalence or epidemiological studies available now, and the prediction of increase of type 2 diabetes mellitus and obesity, plus the aging process, we think, or in the future, there will be more aging in our population, plus more cases of obesity and type 2 diabetes mellitus. So this diagram in this table, you can see in 2030, how many cases of NAFLD expected or NASH expected in 2030. More than 2.6 million. Another diagram will make it much easier. You can see here, of course, the study was done for Saudi Arabia and the United Arab Emirates, but I selected the slides for the Saudi Arabia. You can see here the fibrosis, even fibrosis stages and higher stages will be expected in 2030 because of the aging plus the increase in the obesity and diabetes mellitus. You can see here in 8,451,000 and expected to be 12,530 cases. So this is a very important slide. Now, prevalence of NAFLD, why NAFLD is important worldwide nowadays. You can see the trend. Very important diagram, which is the one in the left. Here you can see the diagram, which is colored by blue, how much increase. So if you baseline, they started in 1988 to 1994, and how is the progression of cases of liver cirrhosis or chronic liver disease secondary to common causes, are hepatitis B, C, NAFLD, and alcoholic liver disease. And you can see there is trending down on hepatitis B and C cases. If you go back, if you go to the one with the stars, which is the diagram of Hep C, you can see there is in 2013 to 16, 60% decrease in the cases that we know because of the invention of new treatment for hepatitis C. However, in the top, the alcoholic liver cirrhosis, let's say almost stable for the last 10 to 15 years, but NASH is ongoing up, creeping up, increasing. You can see almost 60% increase from baseline, which is in 1986 to 2016. And the table here on the right, you can show the correlation between the metabolic syndrome or the type 2 obesity, type 2 diabetes and obesity, hypercholesterolemia and hypertension. And the most important factor, two factors here, obesity and type 2 diabetes mellitus, just closely related. Odds ratio in people who have obesity to have NAFLD is 10.3, very high, 10.3. And type 2 diabetes mellitus is 3.6. This is the odds ratio, the risk of having NAFLD in type 2 diabetes increased to 3.6, means 360% increase compared to general population or compared to the controls. This another table will summarize you the risk factors for NAFLD and how does it affect the prognosis of NAFLD. As we mentioned in the model study done in Saudi Arabia, they expect greater effect of NASH on our population because of the advancing age. In the middle of the schedule, in the middle of the table, you can see the hypertension, central obesity, insulin resistance. How does it affect? It's 66% prevalence of bridging fibrosis if the patient is more than 50 plus diabetes or obesity. So mainly we're talking about, again, obesity and diabetes. And other lab values, as you see in the table, the prognostic factors, how if these are present, how can you prognosticate or predict the prognosis of your patient. In 2020 many studies, they are talking about NAFLD as muffled. What do they mean by muffled? There is great association between metabolic syndrome and alcoholic fatty liver disease. NAFLD, non-alcoholic fatty liver disease. There's a great association between the metabolic syndrome and NAFLD. So they used to say NAFLD is the metabolic, I mean the liver manifestation or hepatic manifestation of metabolic syndrome. And they used to use the terminology now metabolic dysfunction associated fatty liver disease, muffled. Instead of NAFLD, they use the terminology. It is used in many studies, 2 or 3 studies are talking about muffled, not NAFLD anymore. So they're talking NAFLD is clearly associated and strongly associated with this collection of metabolic risk factors, type 2 diabetes mellitus, and hypercholesterolemia and obesity. So what is the natural history of NAFLD and why NASH is important? And how NASH or steatosis is important and why it is important. You can see the progression of, in this diagram, of steatosis, the percentage of progression from one stage of steatosis to NASH to advanced fibrosis, cirrhosis, and how can it progress to HCC and death. And percentages written and very clearly explained in this diagram, illustrated. Okay, so how do you diagnose NAFLD? How can we assess this patient has fatty liver disease or not? Gold standard to diagnose NAFLD is liver biopsy, but liver biopsy is invasive. So other modalities, which is, let's say, gives prediction this patient has, not prediction, enough to diagnose NAFLD are the MRI spectroscopy, the proton density fat fraction, qualitative fat water selective MRI. These are like expensive and not usually feasible in the clinical settings. So the trend was to find non-invasive or non-expensive modalities to diagnose NASH. In appropriate clinical setting, steatosis can be predicted non-invasively with ultrasound. Reliably can diagnose NAFLD more than 90% sensitivity if the steatosis involved more than 33% of the liver. As we said, normally the liver has less than 5% steatosis only. More than 5% can be diagnosed with MRI or biopsy, up to from 33% and above reliably can be diagnosed by ultrasound. So it is the recommendation is to start with ultrasound liver, not to proceed with liver biopsies. And I will show you a diagram how to approach people coming from first time to the clinic. How do we approach it? There are biomarkers, fibrosis scores, elastography, which is the fibroscan, acceptable non-invasive procedures to identify low-risk patients for fibrosis versus high-risk patients for fibrosis. So this is a non-invasive measure to assess the liver. Patient, the recommendation from the EASL, patient with insulin resistant and or metabolic risk factors, obesity and metabolic syndrome should undergo procedures for the diagnosis of NAFLD, which is initial screening by ultrasound and to apply the NAFLD scores, fibrosis scores. I will come to reinforce on them in the next slide. So this is the diagram suggested by Dr. Villar-Gomez in 2018, and it's published in the, EASL, it is presented in EASL. You can see the potential algorithm for non-invasive assessment. As we say, the gold standard is liver biopsy, but it is invasive and not every patient needs liver biopsy. So if the patient has high liver enzymes, risk factors like metabolic syndrome or high liver enzymes or imaging showed fat accumulation, then fat accumulation by ultrasound, do ultrasound, showed fat accumulation. Next step to classify the patient low risk for fibrosis to high risk for fibrosis. And the two well-known scores known to everybody, which is FIB4 index and NFS score, the NAFLD fibrosis score. This score is low, and majority of people are low, which is 55 to 58% of people are low risk. Then people is low risk, then can proceed with family care or primary care assessment every 2 years, repeat ultrasound and modification of risk factors. If the patient is high risk, which is the score showed high, plus ultrasound showed fatty liver, then which is seen in 12 to 15% of cases, these people are classified as high risk for fibrosis, and the next is to do liver biopsy. The people in the middle are intermediate risk, which are people which is intermediate risk between low and high. It is seen in 30% of patients be diagnosed as NAFLD by ultrasound, and we do need further further studies by fibroscan and ELF test. So let's proceed with the treatment of NAFLD. What do we have for the treatment of the NAFLD? To be honest with you, in hepatology clinic, people who came to us for hepatology opinion, we do the workup and to rule out other causes of high liver enzymes or fatty liver, or assess the patient with risk factors. And this is the main slide we're using in the clinic. So what are the advice we give for patients with NAFLD? As we said, diet and lifestyle modifications. So the most important is 7 to 10% weight loss, and I will show you what's interesting in the next triangle here, but let me finish on this slide. There is no specific recommendation regarding the coffee. Nutrient diet, we need patient to be low to moderate fat diet, moderate to high carbohydrate, low carbohydrate ketogenic diets, or high protein. There's the type of the diet. Physical activity, we advise the patient to walk or do exercise 150 to 200 minutes per week, moderate intensity. Daily alcohol intake strictly should be less than 30 grams for men and 20 grams for women. The other one is the fructose. Fructose is, again, is one of the for diet. It was a study that showed it can increase the hepatic steatosis, fructose by itself, plus the alcohol. And so this is the main slide we're using, main lifestyle modification we're using in the clinic. So why this lifestyle modification and diet is important showed in this study done by Dr. Gomez in 2015. It showed more than 10% weight loss, fibrosis improved. So histological improvement, 45% in fibrosis. NASH resolution seen in 64 to 90% if the weight loss more than 7%. Inflammation will decrease in 40 to 100% if the weight loss is more than 5%. Steatosis will decrease if the weight loss more than 3%. So you can see the variation is based on the weight loss. So what we are concentrating on is fibrosis and above. I mean, NASH resolution, fibrosis. So that's why we advise the people, our patients, to lose weight 7 to 10%. What about bariatric surgery? This is weight reduction now, diet and lifestyle modification for weight reduction. Another weight reduction method is bariatric surgery, regression of NASH and fibrosis by bariatric surgery. This is also a big study done in 2020 by Dr. Leslie. 180 severely obese patients, biopsy-proven NASH, underwent bariatric surgery. And they were followed the patient and at 1 year, biopsy baseline, then 1 year, then 5 years, showed they can see the diagram decrease, improvement of the fibrosis, more than 1 degree improvement in fibrosis. You can see 70% of baseline, it becomes 66% in first year, and 5 years, 36% of people. So great improvement, and it is related mainly to the weight loss. Not only NASH, those people were, when they followed up, a lot of metabolic factors, diabetes, hypertension, improved. Pharmacotherapy. What are the pharmacotherapies that we have? When do we use them? We use them when there is progressive NASH. There is steatohepatitis, not only fatty liver only. So there is steatohepatitis in terms of fibrosis, severe inflammation. Then we should start treatment. And we'll come in a while. What treatment should we start? Early stage NASH with risk of fibrosis progression, which can prognosticate by presence of risk, metabolic factors. Active NASH with high necroinflammatory activity by biopsy. However, so far, up to date, no drugs are approved for NASH. No drugs approved for NASH. So what are the common medications have been used or have been talked about by people and their efficacy? Is there efficacious in treatment of NAFLD or not? Metformin. There is only little evidence of histological efficacy with metformin. So little evidence that metformin might help. Although we know that insulin resistance is the main, one of the major pathophysiology behind the NASH, but metformin, there is little evidence that metformin is beneficial, so not advisable. Bioglitazone was studied in diabetic patients, NASH proven by biopsy. It showed improve all histological features except fibrosis. So improving inflammation, ballooning, and these things, but doesn't not improve the fibrosis, which is the main goal because the risk factor, complications comes after fibrosis. And there's concern about side effects there by glitazone. Vitamin E, it has been used also because the only medication was available. So non-diabetic patient it is studied in non-diabetic patient with biopsy-proven NASH, may improve, so mild to moderate, low to moderate level of evidence showed improve steatosis, inflammation, and ballooning, and resolve NASH in some patients. Still, there's no improvement of fibrosis. There is concern about long-term safety exists. Even any medication of them, bioglitazone or vitamin E, they are off-label, but if used, should be reassessed in 6 months for the efficacy. If not efficacious, then should be stopped. Next is statin, has not been adequately tested in NASH, can be used for hyperlipidemia, not for NASH. So this is the medications available now. As we said, none is approved. What are the future therapies? The future therapies, they are targeting many areas of pathophysiology. We talked about pathophysiologies At the metabolic level, there is pathophysiology. I mean, there is pathogenesis at the fibrosis level, inflammatory level. So many drugs are studied here. You can see the colors in pink showing the areas of target for new therapies for NASH. Some of the drugs target the metabolic level, and some of the drugs target at the inflammatory level, and some of the drugs target at the fibrosis level. So where we are, this you can see the huge trials ongoing worldwide at different levels, phase 1, phase 2, phase 2B, phase 3, and pre-regulatory trials. These are ongoing trials. It can explain why we have this number of trials ongoing, because there is no drugs so far proven to be effective in NASH. So let's quick review about the phase 3 trials, which is expected to be released in the market soon. So let's go to therapies for NASH in phase 3 development. We have a few drugs here at the last stage, which is the phase 3. Before the pre-regulatory phase 3. We have obeticholic acid. Obeticholic acid have been used it for a long time. Let's say 10 to 15 years, where you have been using it for primary biliary cirrhosis. Primary biliary cirrhosis, it is one of the chronic liver diseases. So obeticholic acid have been used there and tried here as anti-fibrotic agent and anti-inflammatory for NASH, and it is in phase 3. Will come in a while. And the primary endpoint, most of them was NASH resolution, more than one or increase, more than one stage improvement in fibrosis without worsening of NASH or fibrosis. And there are some metabolic modulators like ilfavirenor, remesitrom, and armacol. These are ongoing trials. Let's come quickly on them. Obeticholic acid, this is the, let's say, most striking one, which is the almost about to finish. It is done by Dr. Younussi. They called the Regenerate phase 3 trial. You can see the effect. It is what people are followed for 52 weeks, I guess, 18 months, 72 weeks. Primary outcome was improvement of fibrosis and no worsening of NASH. They used 2 doses of obeticholic acid, 10 milligram and 25 milligram. And importantly, that 25 milligram compared to placebo showed improvement in fibrosis, 38% compared to 23% in the controls, and the other one is 11% to 23% at 18 months, which was clinically significant. Side effects showed from obeticholic acid, which is expected, some itching, but increased LDL maybe will be an issue. But as they mentioned, LDL increased readily responded to statin therapy. Next medication, which is the resmetirom, which is the thyroid hormone beta receptor agonist. 36 weeks trial in phase 2, 125 participants with NASH. All of these randomized trials. Intervention 2 to 1 ratio, 80 milligram remesitrom given versus placebo. Primary outcome was decrease in the fat fraction by MRI, and it showed significantly improving the steatosis from 68% at 36 weeks to 30% in placebo, the improvement of fat or steatosis. Another drug called the sterol-co-desaturase, also it works at the metabolic level, not the fibrosis level. It is liver targeted sterol-co-desaturase inhibitor. Again, placebo effect, the placebo showed 5% and the armacol 600 showed 16.7% improvement in steatosis and fibrosis. Another important medications have been used for obesity to decrease weight, which is the liraglutide. Liraglutide, it was studied for 48 weeks, 52 participants with clinically evidence NASH. Liraglutide 1.8 milligram versus placebo showed the improvement. You can see the ballooning, inflammation, fibrosis. The improvement resolution of NASH seen in 39% of people using liraglutide in compare with 9% of the controls. And the critical appraisal for this study that could be weight reduction related, not the medication effect itself. So because the medication decreasing the weight and this improve the NASH. Semaglutide is another also drug have been used. They studied 320 participants with NASH, fibrosis stage 1, 2, 3, and they used 3 doses of semaglutide, 0.1 to 0.4 milligram. Again, showed importantly resolution of NASH, no worsening of liver fibrosis. So again, decrease NASH by in 59% of cases, and liraglutide in 39% of cases. The number of patients here higher, 320 patients, again, could be related to weight loss rather than medication effect by itself. So this diagram this is the last slide here, it can show you what are the medication, what are the effects of them in the summary of the ongoing trials or latest trials. You can see most of the medication that we talked about here, the elafibranor, obeticholic acid in 2 trials, armacol, imricasan, and semaglutide and liraglutide. You can see some of them affect mainly on steatosis, like semaglutide, and some of them the effect on fibrosis more, like imricasan. Some of them combined effect like obeticholic acid. So this is the study where we are in new trials. Conclusion. So NAFLD is becoming most prevalent liver disease worldwide with epidemic of obesity and metabolic syndrome. It is expected that NAFLD will become the most common cause of end-stage liver disease worldwide in the near future. So it's expected to be the #1 cause of end-stage liver disease in the near future. So that's why it is important. Evidence shows that most effective treatment modality for NAFLD is weight loss. If you see most of the medication showing effect mainly by decreasing weight. That's why we enforce on the patients, on the primary care physicians, on ourselves to reinforce the patient for weight loss. This is the major modality, weight loss 7 to 10%. So far, no drugs approved for NAFLD treatment. There are a large number of ongoing trials, as I showed you, for NAFLD treatment with variable results. Thank you.
Thank you, Dr. Fouad, for this nice presentation, clear and comprehensive. This floor now open for questions. There is a question currently is a patient with fatty liver and overweight or obese. So what you will do for them usually? Do you push them for like bariatric surgery, or you try with like steps wise?
Should I answer?
Yeah, please, if you don't mind.
So regarding the obesity, I mean, the obesity, we know that the obesity classification of obesity is it morbid obesity or it is overweight, and overweight means in the BMI 25 to 30, is BMI 30 to 35, it's called obesity. So for obesity, regardless if you prefer to refer the patient to bariatric surgery or not, you have to start with the diet and lifestyle modification. This is the most important. So you start with the diet and lifestyle modification. You advise the patient to avoid to modify his diet, exercise, weight loss of 7 to 10%. And if it is morbid obesity, yes, from the beginning, I would refer the patient to bariatric surgery plus the diet and lifestyle modification.
Okay. There is another question. Do we need to do an ultrasound for all our patients to detect like fatty liver?
high-risk patients advised by EASL guidelines in 2016, high-risk patients, which we mean obese patient with hyperlipidemia, diabetes, any patient who have metabolic syndrome, yes, they are advised to do initial screening for steatosis, which is starting with ultrasound. Yes, high-risk patients.
Okay.
The screening of population is just a dilemma. And should we screen all population? I mean, anyone comes to the clinic, should we screen for NAFLD or not? This is a dilemma. Why? Because still we don't have active treatment. This is one. And the other things, there is the validity of most of the fibrosis assessing modalities are invasive. Some of them are expensive. But initial ultrasound, they're advised, they don't advise us usually for all population, as with the limitation of its sensitivity and the limit and the non-availability of the drugs to treat NASH. But high-risk patients, yes, with metabolic syndrome.
Okay, this is another, maybe the last question. What about like vitamin E? You mentioned that it's in non-diabetic patient, long-term efficacy or like a safety is questionable. So do you advise or not which patient you will give, or there is nothing like clear yet?
Well, vitamin E was, studied in people who had biopsy-proven non-diabetics. So if non-diabetic, and we have to be concerned about the long-term safety of high-dose vitamin E. More than 800 is concerned, plus the safety regarding the progression, risk of prostate cancer. So people only NAFL, only fatty liver is not advisable. It is advisable for NASH, and it is biopsy-proven NASH. But if fibrosis score high, we use to advise the patients to be referred, fibrosis score high plus high liver enzymes, to be referred to hepatologists to decide about the further management. But for NAFL, only fatty liver, no, it is not advisable. It is advisable for NASH only. Steatohepatitis means there is inflammation, fibrosis with fatty liver.
Okay, so we need to do like a liver biopsy before like deciding. Yes. Okay, yes. That's perfect. Any other question? So we'll conclude at this point. Thank you, Dr. Fahd, for this presentation again. And thanks for people attended. Today is World Obesity Day. So and obesity is a major risk factor for fatty liver disease. Take care and have a nice day. Thank you.
Thank you, everyone. Thank you for your attendance.